Okay, rad techs, grab your lead aprons and your coffee. Today, we're working our way down the upper extremity, covering the humerus, elbow, and forearm. If you've ever second guessed your CR location or forgot which oblique shows the radial head, this is the one to watch. As always, we'll break down each view into 2 slides, a setup slide and an evaluation slide, so you can nail both the positioning and the image critique on the ARRT CQR. All right, AP humerus. Your patient is either erect or supine, the arm is slightly abducted, and the humerus is fully extended. Supinate the hand so that the epicondyles are parallel with the IR. That's the magic trick to keep from rotating the humerus. The central ray is perpendicular to the midpoint of the humerus, and your SID is a standard 40 inches. Your technique should be between 70 and 75 kVp, low mass, and a small focal spot. You don't need a grid for average adults unless pathology requires higher detail with less scatter. The anatomy visualized here is the entire humerus, including both shoulder and elbow joints. Radiation protection, you want to shield the patient's gonads and thyroid when possible, especially in pediatric patients. Communicate clearly so they don't move, and collimate to just beyond the joints to cut dose. Here are some ARRT tie-ins. On your image acquisition, alignment is critical to avoid rotation. Image evaluation, you want to see open joint spaces at both ends. Your equipment, AEC isn't typically used here because the anatomy is long and variable. You don't want to clip at either joint. Okay, let's break down exactly what you're looking for in your final AP humerus image and why each element matters. First, coverage. You absolutely must have both the shoulder and elbow joints fully included. If you clip either one, it's a repeat. The ARRT will mark that wrong in an image critique question, and in real life, the radiologist can't evaluate alignment, fractures, or joint space without the full picture. Second, tubercle visibility. The greater tubercle should be clearly seen in profile laterally. In a true AP, the greater tubercle swings out laterally and away from the humeral head. If it's not visible, you're probably rotated internally. Third, the humeral head should be partially seen medially overlapping the glenoid cavity, just a bit. Too much overlap means you're rotated. No overlap at all means the arm is over-rotated externally. Fourth, epicondyle alignment. On a perfect AP, the medial and lateral epicondyle are parallel to the image receptor. That's your quick visual check for rotation before you even make an exposure. If they're not parallel, the rest of your anatomy is going to be off. Fifth, motion control. You want crisp, bony trabeculae throughout the humeral shaft and joints. Any fuzziness means motion blur, usually from the patient trying to adjust because the position is uncomfortable. This is where patient care matters. Support the arm, explain how long the exposure will take, and reassure them. Common errors to watch for are clipping a joint, that's the biggest repeat reason. Epicondyles not being parallel, that would be rotation. Motion blur. Internal rotation, which you can spot by the lesser tubercle popping into profile medially. That's a dead giveaway. Here's a quick tip. If you suspect internal rotation, just check the hand. If the palm is facing the patient's thigh instead of forward, you need to supinate. All right, next up, the lateral humerus. This is our orthogonal view to the AP, meaning it's at a 90-degree angle and it's essential for fracture evaluation. You can do this either erect or supine, but standing gives you more room to maneuver the arm. Internally rotate the arm so that epicondyles are parallel to the IR. This is the single most important step for a true lateral humerus. Flex the elbow about 90 degrees with the palm resting against the patient's abdomen. This is the classic positioning for a non-trauma patient. Make sure the shoulder, elbow, and wrist are in the same horizontal plane. Dropping the shoulder or bending the wrist will throw the forearm out of alignment and distort the anatomy. Your central ray is perpendicular to the midpoint of the humerus. Your SID is 40 inches. You want to use a similar technique as your AP, around 70 to 75 kVp, small focal spot, enough mass to visualize trabecular detail without burning out cortical bone edges. Special notes for trauma. If the patient can't rotate the arm, you'll use a transthoracic lateral. The injured arm stays against the IR, the unaffected arm is raised above the head, and the CR passes through the thorax. You'll need to increase mass to punch through the chest tissue. You can use a breathing technique, low MA, long exposure to blur the ribs and lung markings, which makes the humerus easier to see. Patient care, always support the arm. In trauma, don't remove slings or splints unless cleared by a provider. Safety, shield the gonads when possible, and always confirm patient ID. Image production. Perpendicular epicondyles give you a true lateral. Any tilt will cause the humeral head to project incorrectly. Here's what you should see in your final lateral humerus. Epicondyles superimposed. This is a hallmark of a true lateral. If they're separated, you've got rotation. The lesser tubercle should be in profile medially, a nice rounded projection on the inside of the humerus. The greater tubercle will be partially superimposed over the humeral head. Bony details should be sharp, no motion blur. This is especially important if you're dealing with subtle fractures or evaluating post-op hardware. Both the shoulder and elbow joints must be included. Again, clipping is an automatic repeat. Now, let's look at the transthoracic lateral humerus closer. This is our go-to trauma alternative when the patient cannot abduct or rotate the injured arm. The purpose is to give a lateral projection without moving the injured limb, preserving fracture alignment, and minimizing pain. It's often used for proximal humerus fractures, post-reduction checks, or when shoulder injuries make standard positioning impossible. Your patient stands or sits upright at the upright bucky or supine on the table if needed. The injured arm stays against the IR. Do not attempt to rotate or reposition it. The unaffected arm is raised straight up over the head. This moves the opposite humerus and scapula out of the way. Encourage the patient to drop their shoulder on the injured side as much as they can. This opens the thoracic inlet and separates the humerus from the cervical spine in the image. Your central ray is perpendicular to the IR, directed through the thorax at the level of the surgical neck of the humerus. Your SID is 40 inches, though sometimes 72 is used for upright trauma if the equipment allows for it. You want to use a higher mass to penetrate the thorax. Think 80 to 85 kVp with sufficient mass for chest thickness. A breathing technique is often used, low MA with a long exposure time, around 2 to 4 seconds, while the patient takes shallow breaths. This blurs the ribs and lung markings while keeping the humerus sharp. If motion control is more important, like in uncooperative patients, suspend respiration at the end of inspiration or expiration. Shield the gonads when possible, mate to just beyond the humerus to reduce scatter. Here's your ARRT tie-ins. Patient care, we want minimal movement of the injured limb. Clear communication about breathing instructions. Safety-wise, follow your trauma protocol. Do not remove splints or slings unless directed. Your image production. Breathing technique and correct arm elevation are essential for a diagnostic image. In your transthoracic lateral humerus image, here's what to look for. The entire length of the humerus is visible. Though sometimes the distal portion may be obscured by thoracic anatomy in very large patients, the humeral head and shaft should have good cortical detail without being washed out. The unaffected shoulder should be moved completely out of the field. If it's still overlapping, the patient didn't raise the arm high enough. You should see the humerus through the rib cage. Ribs and lung markings will overlay, but the humerus edges should still be sharp. Trabecular pattern in the bone should be visible without excessive quantum model. Here's your exposure check. If the humerus looks ghost-like and too light, you over-penetrated. If the humerus is swallowed by the ribs and soft tissue, underexposure. Here's some common errors. Unaffected arm not raised high enough results in overlap of the shoulders. No breathing technique used. Ribs appear crisp instead of blurred, distracting from the humerus. Motion blur from the patient moving during the long exposure. Here's a quick tip. If the patient can't stand, you can do this supine with the injured arm alongside the body and the unaffected arm over the head. But watch your CR angle and ensure the thorax is centered to avoid cutoff. With the humerus projections out of the way, it's time to drop down to the elbow. That hardworking hinge that gets far more credit in sports medicine than it does in radiography. In imaging, though, it's just as critical. The elbow is where the distal humerus shakes hands with the proximal radius and ulna, forming not one, but three joints in a single space: the humero-ulnar, humero-radial, and proximal radio-ulnar joints. The ARRT loves the elbow because it's a gold mine for testing anatomy knowledge, positioning accuracy, and adaptability when patients can't move well. So let's walk through every standard projection and its trauma adaptations, covering positioning, patient care, technique, safety, and all those little Q&A checks that keep images repeat-free. For a proper AP elbow, think perfectly level table and perfectly level limb. The patient is seated at the end of the table with the shoulder, elbow, and wrist in the same horizontal plane. This isn't just for comfort, it's an image production principle. If one of those joints is higher or lower, the joint spaces close, distortion creeps in, and suddenly that perfect AP becomes a retake. The arm is fully extended if possible. The hand is supinated so the palm faces the ceiling, and that instantly makes the epicondyles parallel to the image receptor. This parallel relationship is your built-in rotation check before the exposure is ever made. The central ray is perpendicular to the mid-elbow joint with a standard SID of 40 inches. Most techs will use 60 to 65 kVp with a small focal spot for crisp bony detail. No grid is needed here for the average adult. The part's too thin, and a grid will just steal photons and add unnecessary dose. From a patient care and safety perspective, tight collimation to the joint is essential. This keeps exposure, ALARA, and improves contrast by cutting scatter. Gonadal shielding should be used when practical, especially for pediatric patients. And here's the big trauma safety note. If there's a suspected fracture or dislocation, never force the elbow into full extension. If the patient can't extend, there is an ARRT approved adaptation for that, which we'll get to in the evaluation section. The anatomy demonstrated includes the distal humerus with its medial and lateral epicondyles, the capitulum and trochlea, the proximal radius and ulna, with the radial head, neck, and tuberosity, and the olecranon process, tucked neatly into the olecranon fossa. A perfect AP elbow image will show the proximal radial ulnar joint open and the radial head partially superimposed on the ulna. That's normal anatomy in this view. The epicondyles will be parallel to the IR, meaning there's no rotation. The joint spaces should be open, and the bony details should be sharp enough to count trabeculae if you wanted to. If the patient cannot extend fully, the correct protocol is to perform 2 AP projections, one centered on the distal humerus and one on the proximal forearm. That way, both ends of the joints are covered without putting the patient at risk. From a Q&A standpoint, here's what can ruin the image: clipping either the distal humerus or proximal forearm, rotating the limb so the epicondyles aren't parallel, or allowing motion blur from discomfort or poor immobilization. And yes, if the radial head is completely overlapping the ulna in the AP, rotation is off and you're headed for a retake. Once the AP is in the bag, it's time to swing into the lateral, a true orthogonal view, and one of the best tools for spotting hidden fractures through fat pad signs. The lateral projection starts with a 90-degree elbow flexion, not 80, not 100, 90. This specific angle pulls the olecranon process out of the olecranon fossa, opens the joint space, and creates the geometry radiologists expect for evaluation. The thumb points upward like it's hitchhiking. This prevents the radius and ulna from crossing unnaturally, which would obscure the radial head. Just like with the AP, the shoulder, elbow, and wrist must be in the same horizontal plane. If the shoulder is lower or higher, the condyles won't superimpose and the image will be off. The central ray is perpendicular to the mid-elbow joint at a 40-inch SID. Technique factors remain similar to AP, 60 to 65 kVp, small focal spot, no grid. Tight collimation again improves contrast and reduces dose. Anatomy visualized includes the olecranon process in profile, the distal humerus, the proximal radius and ulna, and those all-important anterior and posterior fat pads, which can signal a occult fracture before any cortical break is visible. In a true lateral, the humeral epicondyles will be perfectly superimposed. The olecranon process will be sharp and clearly profiled posteriorly, and the radial head will be superimposed over the coronoid. The humeral condyles should appear like two coins stacked neatly. Under rotation causes the epicondyles to separate, while over rotation pulls the radial head away from the coronoid process. Both are positioning errors that compromise diagnostic value. In trauma cases, the posterior fat pad sign is a big red flag. If it's visible, there's a strong likelihood of a fracture, even if the cortical bone looks intact. AP and lateral give a great overview, but obliques are where overlapping anatomy gets separated for a closer look at specific structures. The lateral external oblique starts from the AP position with the entire arm rotated 45 degrees outward, shoulder, elbow, and wrist together. This rotation frees the radial head, neck, and tuberosity from ulnar superimposition and profiles the capitulum. This is the go-to view for radial head fractures. The medial internal oblique is the mirror image. The entire arm rotates 45 degrees inward. This puts the coronoid process in profile and shows the trochlea clearly. It's a favorite for detecting coronoid fractures. Both obliques are centered to the mid-elbow with the same exposure factors, 60 to 65 kVp, small focal spot, no grid, and collimated tightly to the joint. Evaluation in a proper lateral oblique. The radial head and neck are completely free of ulnar overlap, and the capitulum is in profile. In a proper medial oblique, the coronoid process is fully in profile, and the trochlea is sharply defined. The most common error here is rotating only the forearm instead of the entire arm. This keeps the humerus in an AP orientation while the forearm twists and the structures remain overlapped, defeating the purpose of the view. Some patients can't tolerate any of that rotation. That's when the trauma axial Coyle method steps in. The Coyle method replaces obliques when the elbow can't be moved due to pain, surgery, or fracture stabilization. For the radial head projection, the elbow is flexed to 90 degrees and the central ray is angled 45 degrees toward the shoulder. For the coronoid process projection, the elbow is flexed to 80 degrees and the central ray is angled 45 degrees away from the shoulder. This geometry allows visualization of the same anatomy as the obliques without rotating the arm at all, an ideal patient care adaptation in trauma. In the radial head view, the head and neck are completely free of ulnar overlap, and the joint space between the radial head and capitulum is open. In the coronoid process view, the coronoid is elongated and in profile with the trochlea clearly visible. Incorrect angles or flexion will leave the anatomy overlapped, reducing diagnostic value. Because this method is less common in routine imaging, the ARRT loves to include it in image critique questions. After the elbow, the next stop is the forearm, the long road between the elbow and the wrist, home to the radius and ulna. The forearm doesn't get as much glamour time as the shoulder or hand, but it plays a key role in everything, from turning a doorknob to holding a coffee cup. In radiography, forearm imaging is deceptively simple. The anatomy is straightforward, but there are a few golden rules from the ARRT that will make or break your image quality. In the AP projection, the goal is to keep everything as straight and flat as possible. The patient sits at the end of the table with the shoulder, elbow, and wrist in the same horizontal plane. Yes, we keep saying this because it's that important. A dropped shoulder or raised wrist introduces distortion and can throw off joint space visibility. The arm is fully extended, the hand supinated so the palm faces upward, and the epicondyles are aligned parallel to the image receptor. The central ray is perpendicular to the midpoint of the forearm with a standard 40-inch SID. For technique, most forearms image well at 60 to 65 kVp with a small focal spot for fine detail. No grid is needed for the average adult. The part is too thin for the grid to be worth the dose. From a patient care perspective, ensure the limb is supported from wrist to elbow to reduce muscle strain. Shield the gonads when possible, especially for pediatric patients, and collimate just beyond both joints to cut dose and improve contrast. The anatomy demonstrated includes the radius and ulna in their entirety, along with both the proximal and distal joints, the elbow, and wrist. This full coverage is an ARRT requirement. Clip a joint, and it's an automatic repeat. A perfect AP forearm shows the radial styloid process in profile laterally and minimal overlap of the proximal radius and ulna. That slight crossing near the elbow is normal anatomy. But the wrist and elbow joints are visible and free of distortion, and trabecular detail is sharp from one end to the other. If the proximal radius is completely overlapping the ulna, there's too much rotation. If the wrist joint is closed, the shoulder, elbow, and wrist probably weren't in the same plane. And yes, if either joint is missing from the image, the exam must be repeated. No exceptions. With the AP done, the lateral forearm steps in to give the second orthogonal view, critical for ruling out fractures and checking bone alignment after injury or surgery. In the lateral projection, the elbow is flexed to 90 degrees, the thumb is pointing straight up, and the forearm is in true lateral position. The patient's shoulder, elbow, and wrist must remain in the same horizontal plane. If the distal forearm drops, the bones will look distorted and the joints will close. The central ray is perpendicular to the midpoint of the forearm at a 40-inch SID. Technique remains in the same range, AP, 60 to 65 kVp, small focal spot, no grid. Support the forearm at both ends. Keep the patient comfortable, and to minimize motion blur, collimate to include both the elbow and wrist joints, and shield appropriately. The anatomy demonstrated includes the distal humerus, the entire radius and ulna, and both joints, with the bones superimposed distally. In a true lateral forearm, the distal radius and ulna are superimposed, the radial tuberosity is facing anteriorly, and the humeral epicondyles are superimposed. Both the elbow and wrist joints are clearly visible and in profile. If the radial tuberosity is rotated posteriorly, the forearm has rolled back. If the distal radius and ulna aren't superimposed, the forearm is tilted or the wrist dropped out of plane. As with the AP, missing either joint means a repeat. The ARRT is strict on that point. With the forearm complete, the entire span from the shoulder to the wrist has been covered. The humerus, elbow, and forearm projections not only build the foundation for upper extremity imaging, but also reinforce the same core principles. Keep the anatomy in the same plane, align landmarks parallel or perpendicular to the image receptor as needed, and never compromise on including all required anatomy. From here, the journey moves to the wrist, hand, and fingers, where the anatomy gets smaller, the positioning gets more intricate, and the detail work becomes the star of the show. See you in the next one.